Hi, I'm Jill Hopkins. I'm the Senior Vice President and Global Head of Development of Ophthalmology at Novartis. So when I think about persistent retinal fluid, and I think about this both as a retinal specialist having been in practice for 20 years and a drug developer in this space for the last 12 years, really thinking about persistent retinal fluid as one of three important factors in how we think about disease activity. So persistent fluid being one, the structure, the anatomy, if you will. Second, very important one, the function, the vision for the patient. And the third really important one is the frequency or burden of injections associated with trying to maintain structure and function. So it's really that triangle of how do we manage that. And we know that persistent retinal fluid is problematic. Even in the face of good anti-VEGF agents, there are 50% of patients that still have persistent fluid. 50% of patients require injections more frequently than 8 weeks, and about 60% of people fall off therapy by the end of year one. So we know there's a lot to be done to try and tackle some of that unmet need. How to manage that persistent fluid, particularly from a drug or pharmacology aspect, we think, well, what can we do to have an agent that will dry better, that will maintain vision and require less frequent injections? That would be sort of the sweet spot of trying to manage disease better with less burden and good outcomes. I'll start just by reminding you that our clinical development program in brolucizumab that led to the approval in wet AMD was undertaken in patients who were treatment naive, so newly diagnosed with wet AMD. And we compared brolucizumab to aflibercept, and we looked at a dosing schedule that was 3 monthly loading doses, followed by 8 and 12-week extensions, and had good results in that. It led to the approval. What we were interested in Merlin was trying to understand for some patients, we know there's a lot of heterogeneity in response, right? So some people may do well, extend out to 12 weeks, not need anything more than that. Others may need more frequent injection. And so we were interested in investigating in Merlin, what does more frequent dosing look like with brolucizumab? And importantly, what does that look like in patients who have persistent fluid? So Merlin was designed specifically to say, in patients who have had multiple injections on other anti-VEGFs, what happens when you treat with brolucizumab monthly compared to aflibercept monthly? What do we see? So Merlin was, as I say, designed to kind of answer that question around persistent fluid, switching from one agent to brolucizumab and monitoring that over time. So what we saw from an efficacy perspective was that we were non-inferior in terms of vision with brolucizumab compared to aflibercept. And then anatomically, we were actually superior. So we saw better OCT drying, and we saw more fluid resolution in the brolucizumab treated arm compared to the aflibercept arm, which is important, again, when you consider these were patients that were high anti-VEGF needs, difficult to dry. We saw impact there. So that was very encouraging for us. What we also saw was the inflammation rates in the brolucizumab arm coming in around 9%, which was higher than we'd seen in our pivotal trials, the Hawk and Harrier trials, which ran about 4%. Again, that was with 3 monthly loads and then extended intervals. With monthly, we were seeing more inflammation, more compared to aflibercept. And so that led us to stay with our currently labeled dosing posology, where we again see with 3 monthly loading, extension to 8 and 12 weeks, we have good efficacy in terms of drying and maintenance of vision, which in the setting of persistent fluid is what we're hoping to achieve. Yeah, so I think what we learned from Merlin, which I think is really important, is the efficacy that brolucizumab brings to patients who have persistent disease activity on other anti-VEGF agents. So again, we saw the good impact on vision and the very strong impact on the anatomy of drying exceedingly well. So again, I think what that tells us, in addition to the Hawk and Harrier data on newly treated patients, is that we do see good efficacy with the label dosing that we have. So just to share that, from in the space of diabetic macular edema, which is another indication in retinal disease that we have filed for approval, we see a lot of the same issues for patients, right? So persistent fluid, frequency of dosing, the challenges associated with that. So we're very much looking forward to the review and hopeful approval of Beovu in diabetic macular edema to offer options for patients there as well.